You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. Today's episode brings together two exceptional leaders from Penn Medicine, Dr. Anna Schoenbaum and Dr. Srinath Adusumalli, for a candid, grounded look at how AI and automation are reshaping clinical work. We discuss how to decide when technology should be used, as well as how nurses and physicians are adopting these tools in very different ways. You'll hear about reductions in cognitive load and pajama time, the emerging pitfalls of automating bad processes, and a forward-looking view of ambient intelligence as more than just note-taking. If you're leading a health system or guiding a physician workforce, this is the kind of pragmatic, hype-free conversation that cuts through the noise and gets at what's coming next. Let's plug in. Anna and Sri, welcome to the podcast. How are you all today?
Doing great.
I'm great, Craig. Thanks for having us.
Well, it's my pleasure to have you back. At least Sri have you back, and Anna, first time. Where do we find you? Where are you hanging out today as we record?
So I am, and Sri and I think we're both in the same building, but we are in Philadelphia on the Penn Medicine campus. That's the University of Pennsylvania Health System.
Why don't you give us like a little bit about your background and how you ended up at Penn Med?
I'm the vice president and the digital application officer, the chief digital application officer at Penn Medicine. I've been here for over 5.5 years and came along here based on just a great opportunity to be part of a great health system. And I've been in healthcare for 30 years. And I started out as a pediatric intensive care nurse, similar to your background.
Whoop, whoop.
Yeah. And just really, along the journey of nursing and patient care, always gravitated toward digital transformation and just really wanting to flip over to doing more for the greater good. And that's how I started in health IT.
Sri, why don't you give us a quick summary of your background?
My name's Srinath Adusumalli. I'm Penn Medicine's Chief Health Information Officer, a cardiologist by training and current practice. I did my medical training all over the East Coast in Virginia, and then at Boston, and then landed here at Penn Medicine in 2014, where I started off as a cardiology fellow. And over the years, ultimately went on to become a faculty member here. Grew an interest due to the phenomenal mentorship here at Penn Medicine in quality, safety, and informatics, and the nexus of those three. And have built a career that sort of centers at the application of informatics and health information technology to clinical care delivery. Did that at Penn Medicine for several years, and then went on to work in industry at CVS Health for several years, doing many of the similar activities. And have been back at Penn Medicine since January of 2025. We're currently lead a team of health informaticists across disciplines. We focus our time and energy in ensuring all types of technologies are developed in collaboration with Anna and other teams to best suit our clinical and business needs of the organizations. And I continue to practice across the inpatient, outpatient spectrum. I do imaging as well as some very simple procedures.
Well, we're going to talk about a lot today. We're going to talk about AI and automation, but let's take a 30,000-foot view and talk about technology. Both of you are clinicians who are dealing with technology day in and day out. But one of the hardest questions when you're trying to apply technology to a problem is, do you need to even do that? And so, Anna, why don't we start with you? How do you decide if A, we have a problem, and B, if that problem is amenable to a technological solution versus something else?
Yeah, well, you bring up a good point. I agree that you really need to listen to understand the problem because not all problems have a technology solution. But I think it's start by listening. We try to understand what are we trying to solve? What are the pain points? Is it just symptoms? Is it more than that? And if you can take just an hour to look at the problem, I think that is really worthwhile because instead of just shooting from the hip of trying to come up with solutions, you're just really thoughtful in understanding, is it training? Is it practice? Is it workflow? Or is it truly a technology that can help the problem and address the issues at hand? So
And Sri, have you ever come across a technological solution that was looking for a problem to solve?
No, I mean, I couldn't agree more with Anna. I mean, I think the way that we're trying to work with our clinical and business teams as a technology organization is to really help them again focus on the problem, help our colleagues really sort of deeply understand, what do we think our qualitative and quantitative sense is of the set of problems to be solved, both for them to understand and then to help us understand. And where I think the role of informatics in particular is to help translate what the problem space is into potentially technology or in many cases non-technology solution. I think too often we jump straight with the solution in mind. And Craig, as I know you talk about a lot, as we talk about, particularly within the confine across our organization and in places like our Center for Healthcare Transformation and Innovation, it's really about the problem and not trying to come with the solution, at least at first, in mind. I think particularly in the AI and the automation space, particularly automation, we don't want to automate bad processes to start with. So even before we jump to the new fancy shiny tech, a lot of the work that I think has to be done is really around, deeply understanding the problem and process, and are there aspects, at a very basic level that can be optimized, reimagined even, as we like to talk about a lot around Penn these days, reimagining the process before we apply any technology to it.
I think I told you this story, Sri, but for Anna and others, I for years have been upset when I had like the CMIO hat on, when folks came to me and said, I need this order set or I need this doc flow sheet row, and I'm like, hey, what you need to do is actually come to me with a problem and not a solution. Tell me what the problem is, and maybe you do need an order set, but maybe there's other technologies out there that you don't need. And I just couldn't understand how people didn't see the benefit of coming with a problem and not a solution until I went to a dietitian, because my cardiologist, who happens not to be you, but someone else, told me that I needed to be on this certain kind of diet. And I met with the dietitian and said, hey, I need to be on this diet. And she said, it'd be much better if you came to me with a problem instead of a solution. So why do you think you need to be on this diet? And I just was like, oh my, the shoe is on the other foot now. So yes, I get it. Anna, you recently co-authored a JAMA Network Open study that evaluated ambient scribe tools and at least in the outpatient area. What did you find? What are some of the key takeaways from that study?
Yeah, we had so much new findings from this launch, and we started early on. We began our small pilot in 2023 as an early adopter of a product. And we just did it with 15 licenses, just do a little sniff test in primary care and to see if the technology had any merit. And we quickly found out that people really enjoyed using it. People started using the word, this is a game changer. This has been really helpful in my workflow. So we decided to expand it to 50 providers, and that's what the study was about. This was 50 providers across 2 Epic platforms, primarily in the ambulatory primary care space and specialty. And we studied our 50 providers, just looked to see, how it made a difference. It was 17 specialties. And I believe our work was one of the first work of ambient that shows statistically significant improvement in how they use the tools. We did these AI tools, did more than generate notes. What we heard from our providers is reduction of cognitive load, helping clinicians stay focused and be in the moment with their patient. We also looked at just documentation quality. On the reverse, we did see that the documentation length may be a little bit longer, but does that mean it has better quality? That's something else we're searching. Time in the EHR was less. And then we're looking at clinician satisfaction and burnout. One of the things that we did find is that the time in the notes dropped by 20%. After hours, what we call pajama times, fell about 30%. And then the same day note completion improved by 9%. So providers were closing their notes and completing their day.
So a lot of good things there. Sri, have you heard similar things outside of this study from some of your docs?
Yeah, I mean, I think that is we've heard those themes throughout, not just locally, but I think nationally, the evidence base is supporting some of those early findings. We had talked about in JAMA Network Open, but generally speaking, that folks are able to return or be able to experience some of the joy that they entered medicine to experience in terms of connecting with their patients. And I think it's on both ends, right? It's on the clinician end, but it's also on the patient end in terms of the experience and the connection and the conversation and the relationship that can be built, by being able to focus your attention, through the course of a visit directly back on a patient. I know I'm personally a user of the technologies, and I feel that way. I can turn my gaze from the computer screen back directly into the patient's eyes and have a conversation. And I think that's really the potential of when we think about the potential of AI technologies in general. Our hope and aspiration is that we help to continue to sort of imbue our practice with that the AI will help us even increase the humanity and the human element of the care that we deliver.
Anna, for this particular study, you found that the net promoter score was neutral, meaning the 50 doctors or 50 providers that were in your study basically gave a score of average, not high, not low. But that doesn't seem to go along with the kind of the cosmic energy that we hear about with ambient scribing. What do you think was going on there?
This is because we were early adopters of early technology. We got to dip our toes, thankfully, to be able to test the waters. And I think that's probably the biggest disconnect. This space is evolving so rapidly from what we implemented. Because what we did was, it wasn't necessary the first time around, it wasn't necessary integrated it with Epic. So I think it was a copy and paste. But now it's integrated in Epic. And now you can generate orders. Now you can do a lot more things. So I think it is evolving so fast that with each release that you get a little bit more of this technology. So I bet if we circle back, that net promoter score will go higher.
I think that as many I think now like to say, this is the sort of worst this technology will be at this point. And is another important point, not only to speak about here, but also with expectations with regards to, all of the users of the technology, that we're all sort of working together to help to improve it. It's improving rapidly, whether it's from an integration standpoint, whether it's from an underlying model standpoint, whether it's from the product development on top of the models. The space is moving so quickly. And I think one of the other things that our clinicians, get the benefit of with any of these technologies is being able to see that rapid cycle improvement, right as they're using the technology. And that sort of rapid cycle feedback is another sort of newer aspect, perhaps, to some of the technologies that folks are using at work.
Yeah, that's actually a point I've never really thought of before. Usually it takes years. Sri, you mentioned you're a user of this technology. Can you describe where it works great and where it's not awesome?
Yeah, that's a great question, Craig. And I think that is generally, back to whether it's ambient or other technologies. What we're finding is there is tremendously heterogeneous uptake for a whole variety of reasons. I think that's the case with any new technologies. I think that is also the case for these technologies and ambient in particular, although the pace of uptake of ambient is certainly more than particularly among the provider community, more than most any other technologies. And I think there are parts of, for example, documentation that most will agree that these tools are doing quite well in, and also are quite burdensome. Are the pebbles in folks' shoes is sitting there, for example, writing a complex history of present illness. The tools do generally quite well in taking sort of a conversation and then summarizing the story and putting that into a history that might otherwise take quite a long time of pajama time in trying to write that. I think, particularly in spaces like primary care, we see these tools performing very well. When we start to get into some of the specialty and subspecialty spaces, there is room for improvement, but we're already seeing that improvement as time has gone on. I think that these tools will continue to improve in the specialty spaces. As you go on to other parts of the note, like the assessment and plan, for example, where those become generally more sophisticated and also require some context. I think context is key, and being able to incorporate the context of the patient, other context from the record, prior visits, for example, into the note itself and into the creation of the assessment plan. We'll sort of take that to the next level. But as it stands right now, it's a good starting point. And then we'll continue to improve both for primary care and then for specialists. But there is some differences there in sort of how the tools perform according to the sections of the note. And there are use case differences as well. I think there are some visits, for example, that can be quite highly templated and probably documented on an order of minutes, if not single digit minutes. And so those may actually just be quicker to be done, using, for example, templated tools that come along with our electronic health record, and may even take longer, to go through the process of using the ambient tool. And then there are others that certainly using the ambient tool is faster. So it's not only sort of heterogeneity at a primary care specialist, subspecialist level. It's also even within those spaces, I think particular use cases or even visit types that are differences. And then we're also finding, I think there are differences among individuals in terms of the approach to notes and documentation. And I think there are those that are much more particular, and there might be more personalized elements of the note itself. And right now, I think the current state of the technology is there's, again, still room for improvement around personalizing to individual preferences. And those where those preferences are more important may find a bit less value from ambient tools versus those who maybe hold particular aspects of the way the note is a little bit differently. So I think one of the next frontiers is along the lines of personalizing the structure and the content of the notes itself.
Well, Anna, you're a nurse executive. Your background, again, started as a PICU nurse. How do nurses use AI or ambient scribing differently?
Well, nursing is just starting to dabble with the ambient listening tools or ambient intelligence tools here. You got to try, different workflows with different, in different settings. And so here at Penn Medicine, we have done that. We are right now have ambient intelligence technology in the ambulatory space in the workflow of nurse triage. So that is, I think we are one of the first in the country to dabble in that. And the reason is that we implemented nurse triage, and at the point, it was the same time we were implementing for the provider. And we just said, well, why don't we just try it for the nurses? And we gave it out to, I think, just a handful. And they said, wow, even though it's clunky because it was kind of our prototype, they said it really makes a difference. And they didn't want to go back. And we lost, something happened to one of the licenses, and a nurse couldn't use it one day. And she was just so upset. And so we knew we had something. And so now we have it deployed for nurse triage. We have this tool to 80 nurses. And then we are just about to begin on the inpatient side in the next few months here, or next few weeks, I should say. So we're very excited, very interested in see how nurses can leverage this tool, and we'll learn about the workflows, how we might do the design, the training, simulation labs, because it's very different to be able to talk out loud. I think as a pediatric nurse, I always talk to my patients, but I'm not sure if you do that with adult patients as much. I know when my dad was in the hospital, and because I was in the room, they always talked to me and they always talked to my dad. But that's not necessarily a comfort zone for many of the nurses. So we're going to have to kind of flip the culture of being able to talk to our patients more loudly and just maybe talk to them about their assessment and ask them, again, understand what kind of pain they feel on a pain scale and make sure it gets documented. So just a lot of work by colleagues across the country in this space, and we look forward to learning from them and also to be able to contribute to this field of innovation.
I'm fascinated by what differences we're going to find between how nurses and physicians use the tools differently, or nurses who, like you, have doctoral degrees. Which way are you going to go if there really is a difference? Or maybe there won't be. I don't know. It seems to me like there will be key differences even in the same conversation, at least for the way the documentation appears or the way that the questions are posed. Am I wrong, Anna? What do you think? Where will we be in 4 years?
So right now, because our EHR has flow sheets. It's developed by flow sheets, and we have medication records. But I think maybe, we might look at flow sheets just for trending eventually. And maybe it's more the narrative, like our providers, and it will generate the note for us. It may be more advisory as well. And I think it's really going to change. And we're just at this cusp at what Sri mentioned, that this is probably the technology is the worst. We'll continue to see it improve. And then we'll be able to adapt it to our workflow as we help develop these solutions with our vendors.
Yeah, I think there are some parallels with regards to sort of shifting the interaction. And even in the provider space, I think in particular, for example, many are not used to, including myself, are not used to verbalizing our physical exam in a way that physical exam could get picked up and sort of documented as is in the note. That requires a shift, and it wasn't easy, to start with. So it'll be interesting. I think we'll learn a lot, as Anna mentioned from the pilot. I think the other aspect, as one of our clinical leaders sort of astutely pointed out, is that thus far, and we've pointed out to our ambient partners as well, is that thus far, at least up until this point, I know this is changing as we speak, much of the documentation that we capture is through ambient tools is free form and free text. Whereas, their use case will be capturing discrete documentation, and that could offer some learnings as we also strive to do the same out of some of the ambient documentation that comes on the provider side as well. For example, capturing problems in a discrete way.
Do you describe your cardiac exam to the patient when you're using ambient listening so that the tool can pick it up? I hear an S1 and a split S2, and then that's what this means. Is that how you kind of do it?
I try to. I can say I can continue to practice that, but I do think that does help to build. For example, when oftentimes as cardiologists, we'll look at individuals' necks, and we're looking for something called the jugular venous pressure. At times, it's not the easiest physical exam finding to locate. And we're peering, a bunch of us are staring at someone's neck, and they're wondering, why are we looking at their neck so deeply? And so we explain what we're looking for. I think that this form of documentation sort of extends that to the rest of the physical exam as well, as it's sort of the vehicle for us to have more of a discussion around sort of what are we doing during the course of the visit and partner on that with the patient. So I think that's another good sort of outcome. That being said, there are also, I think there are ways, whether you're someone who wants to do that or is adapting the note, for example, to keep portions of ambient documentation and portions of, structured documentation within the EHR. Those are both options that we've surfaced for our clinicians as well.
So Anna, did you find that there were physicians, I'm kind of looking at internists specifically, who said, hey, I'm kind of lost here because I usually use the time that I'm creating the note to kind of gel all of the findings and all of my thoughts. And, sometimes I figure stuff out as I'm writing the note. And if you take away my note writing ability, because now I don't need to do it, I'm afraid I might miss the big picture. Did you get any of that feedback during the study or subsequently?
We did get some of that feedback. I mean, many of our providers have perfected their template, right? And they're very quick at it. And they felt that if they went to ambient, they would miss those steps. So I think it's what workflow works well for what physician with what setting needs to be factored into. But also at the beginning is they may want to use it just for a portion of their workflow, as Sri just mentioned, and then maybe use their template for the rest. So I think eventually it will have some clinical decision support if you want to do it one way versus other. And they'll say, it may appear with some nudges and say, you missed these components or did you want to document these? So it may have some nudges that may come forward as this technology evolves.
Well, that leads me to my next question, which is, where do you think we're going to be either in the near future? So now, how else are we kind of leveraging AI in new ways? And then where are we going to be 5 years from now?
So I would say, regarding foundation, if you use ambient to provide your technology, whether it's asynchronous or with the patient, but also with other data factored in, I do believe we are collecting data from our vital sign machines or hemodynamic or wearables. And then we have labs and we have imaging results is what kind of documentation is truly needed. We have asked nurses and other clinicians to document extensively, but we have all this information now. could we just provide a summarization report? And that's how you, with the addition of the documentation encounter with the patient or going into the patient and getting some other information. So I feel that it will be more proactive type of documentation and suggestions, and also the data visualization will differ based on your need, and maybe it is based on how you ask or how you think, or maybe set up on your profile. So I think that's just kind of the beginning. In the next couple of years, we'll see this. Maybe I see in the future that there's some surveillance and that we are, again, be able to detect patient deterioration way ahead. And maybe that is by the information in the patient record, but also some of the other tools that may be within a smart room, because there may be things too that may detect falls, maybe changes in gait. But I think the road ahead is very promising.
The world is very, very promising. I agree 100% with Anna. I just go back, actually, Craig, to the prior question. There are various purposes of documentation, and one of those purposes, particularly, depending on the type of visit that you're delivering, is to help us. The process of documentation is also the process of cognition. As we write and as we think, that documenting helps us sort of reason and think through a patient case. Oftentimes, we'll do that. Oftentimes that will be contained within the pajama time. There's friction there, but it's almost a positive kind of friction. In the same way you might write a research paper, the process of doing that research is also, helping you internalize and sort of think about whatever that research question is. And so I think that doesn't mean that the process of documentation has to stay the way it is in order to support our process of thinking about the patient. But we do need to design, to your point, design intentionally. How do we design the structure around ambient documentation to be able to preserve and enhance our ability to think about and reason around, around the cases that we interact with? And I think that'll be, to now answer the second part of your question, that'll be part of what I think the next phases of ambient are. And I think the ambient, it becomes much more of a platform, an ambient intelligence platform, and not just about the documentation. And I think we're seeing this already, right? That platform extends, if you look at even the ambulatory setting, it extends across the arc of the visit, starting, all the way up, potentially upstream, in terms of pre-visit, perhaps working with a patient to tee up information. That then could be through, the next version of pre-visit questionnaires, information that then could be incorporated within not only the note, but into a visit agenda that then could help support the clinician in terms of what to address within conversation. So conversation decision support that then informs the ultimate note that's written, that then is a note that's written to be able to support sort of all the other downstream processes, particularly in the revenue cycle space, like coding and the submission and payment around claims. So I think that whole arc or life cycle of the visit may be and beyond will be supported in some ways by these ambient intelligent platforms. The next step that we're seeing and we're actively thinking about, in addition to the documentation, is particularly the coding and revenue cycle space and the opportunities that might be there.
You're doing your history and asking and interacting with the patient, and then doing an exam, and typically you'll come to some conclusions about, hey, I think this is what's going on. I think this is what we should do next. And put some orders in and some referrals in, and that's all well and good. But then afterwards, you might go to the AI and say, "Hey, what'd you think?" And I could fully imagine the AI saying, "Well, you didn't really address this issue, or how come you didn't think about this syndrome?" If we think that that's not great, at least I don't think that's very helpful after the patient's gone. But I don't know how to incorporate that during the time that we're there without kind of making it look like that we all have a computer overlord that's looking over us and making suggestions that may or may not be appropriate for the patient.
Well, I think that's where, and I don't know if I have a great answer off the bat in terms of what that design should look like, but I think that's where I'm incredibly excited about sort of the work ahead for us in terms of the implementation of AI into clinical care. We focused appropriately on over the years on sort of underlying models, the products themselves, but there's a lot of work to be done on that model of human and computer teaming. You might call it augmented intelligence. You might call it collaborative intelligence. Does that interaction work? And I know there's a lot of, there's science here in terms of human factors and others. Behavioral science, for example, might be able to help support. But there's a lot of work we have to do in terms of figuring out what is that most productive interaction that we should create. What does the UI, what does the user interface look like? I think those suggestions, ideally, these would be forms of conversation, decision support, and in-visit support. How you tee it up without overwhelming either the patient or the clinician while one is still trying to have a positive interaction. I think it can be done, but I think it'll require a lot of work and iteration between us and between our partners.
Anna, any thoughts in this difficult question?
Yeah, I think you will see, throughout the phases of a patient's journey, you'll see information prior to the patient visit, before you walk into the patient's room, during the patient, and then after. So you can imagine using ambient intelligence technology as you prepare for the visit, with the gathering of lab, or maybe the patient reported something through their portal, any kind of care gaps. And don't forget, we have genomic data potentially too, and social determinants of health. And as during that visit, you can pull in that information, and that conversation, it will summarize. If you talk about medications, it could say whether you need a new prescription, to see if there was an allergic reaction in the past. But then also, I think you'll see the connection, and if you need more information from third-party resources, whether it's internal or external, you could have that connection and get evidence right there while you're seeing the patients, because you could tee it up or say, hey, do you want to look at this latest research? After the visit, it could also generate an auto referral scheduling. It could be about drug adherence and close to, contact the patient, and then maybe some close the care gap loop. And then, as we mentioned, regarding maybe on the inpatient setting, is to connect this to the smart rooms, or in the ambulatory setting in the practice exam rooms. But you're going to see, I think, this intelligence, not just in that patient conversation, but it could be during shift rounds, handoffs. So I think there'll be a better, deeper understanding of how this technology works wherever the patient is in the journey.
Yeah, love it. Well, I'm excited. I think the next thing is flying cars, but I'm not going to ask either of you about flying cars today. We'll talk about that maybe the next time. We're running out of time, so I will ask you one more question. What is something in your life that's so well designed it brings you joy every time you use it? Anna, why don't we start with you?
Can I do two?
You absolutely can do two.
I am somebody that loves to capture moments, meaningful moments. And I will say the camera on the iPhone is so dear to my heart, because I take lots of pictures, but then I put them to videos. And we had a family reunion this weekend, and I know those events are not going to be forever. And so I love to capture those moments. And then the last one is just earbuds, just so I can run and listen to my music, and it helps me get through. I'm a runner and just love to have some joy as I run. And I think those are the best technology for me.
All right, Sri, you've done this before. You can't repeat.
I did think about that. I won't repeat the couple I mentioned last time, although they still are some of my favorite technologies. I actually think one picked up since then is drive an electric car. And as you might, if you know, with regards to electric vehicles, they tend to have, some of the newer technologies, or at least redesigned sort of UI and user sort of experiences within the vehicle. And I think the design of this one in particular, does bring me joy every time I use it, because it's the details. The details have been very much thought through, to the experience of the steering wheel, to the surfaces, to even and then, the technology, of course, the technology experiences, which are also quite personalized or personalizable. Even the technologies I mentioned last time and this one, it's that attention to detail and the little details that are what spark the sort of joy and delight. And I think that's also what we want to be able to bring. I think, just to tie that back to our conversation here, is that whether it's the EHR platform itself that we use, or these new technologies that we're incorporating either within or around the EHR, that's the kind of joy and delight that we would strive to bring. And I think in doing that, that's where the details that we've talked about here and others will be important and will help to drive that.
Yeah, it's hard to imagine joy when dealing with the electronic health record, but I feel like we're almost there. We are almost there.
We might not have said that 5 years ago, per se.
Yeah, you would always make it less bad. Like that's what every year was. We're trying to make it less bad, just because people don't generally associate joy with record keeping, and that's essentially what it is. I look forward to seeing where you all go and the progress that you make. Anna, Sri, thank you so much. This was a great conversation. Thank you. Look forward to reading the flying car paper. Thanks for tuning in. We hope you enjoyed today's episode. For more on Anna and Sri, follow them on LinkedIn. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.